Okay. So yeah, so I'm going to tell you a little bit about what's been going on in South Africa, and I'm going to focus mainly on aspects of the epidemic itself and on the response and some of the, I guess, some of the conundrums that we're facing in terms of thinking about exit strategies and what that might mean in this context, and the things that we have to balance. To start off, this is just a map of South Africa. So South Africa, as I'm sure everyone knows, is the southernmost country in Africa, and is made up of 9 provinces. I won't talk too much about the different provinces, but I will at the end focus in a little bit on the Western Cape, where most of the epidemic activity is occurring currently. And I have this quote here from Statistics South Africa, which I think is going to end up being the story of COVID in South Africa. I'm afraid is going to end up being the story of COVID in South Africa, as it is for so many things in South Africa. Inequality in South Africa has long been recognized as one of the most salient features of our society. And I think that's really already starting to show its head, and I think it's becoming a big part of the debate about what's going on, and I think it's really going to drive both the epidemic dynamics and the response moving forward. So the South African population has a population pyramid similar to the ones that, well, sort of almost like a hybrid between some of the ones that we've seen in the other presentations. So it does have this sort of fat middle, but it also has a big base. The population is about 58 million people. And one of the things that is really a big question mark, but also a very important aspect of the South African population, is how the age structure is going to interact with the severity of disease in the context of various comorbidities that are prevalent in the country. So the biggest question mark, I think, in my mind, and I think in many other people's mind, is HIV prevalence. So South Africa has over 7.5 million people living with HIV. A lot of those are virally suppressed, but it is the largest population of people living with HIV in any country in the world. The overall prevalence is about 13%, and it's much higher in some age groups. Sort of working age adults, well, I don't know. Some people would object to that being a working age adult age range. 25 to 44-year-olds, the prevalence is about 23%. And there's very little data so far on what's happening or what the interaction between HIV and COVID is. I've heard arguments in both directions, both that it could be very bad. It's certainly a very bad with other respiratory infections such as flu. I've also heard arguments that there may be some immunological factors that prevent the sort of cytokine storms that are causing some of the really severe disease, and maybe there could actually be a positive interaction. But I have not seen any evidence to back that up. Just seems to be theory. And then there's other comorbidities that I think are potentially very important in our context as well. So tuberculosis is one of them, and not just prevalent tuberculosis, people who are currently infected with TB, but also chronic obstructive pulmonary disease, which is often a result of tuberculosis, it's a post-tuberculosis syndrome, which causes long-term lung damage and is, I think, something that potentially could interact very poorly with severe respiratory illnesses. And then we do, although maybe at lower rates than some other parts of the world, we do have substantial burdens of diabetes and hypertension, cardiovascular disease, as well as other identified risk factors. So I think all of these come together to sort of put a big question mark around what really the interaction between the comorbidities and the age structure is going to be in terms of how things play out for severity in South Africa. This is my slide that summarizes basically everything I can summarize about the South African epidemic, as well, all the basic facts. So currently we have over 11,000 cases that have been identified. The number of deaths is just over 200. And we've been doing a fairly reasonable amount of testing. So almost 400,000 tests have been done at this stage, which I think is, for at least for Africa, is pretty good. On the bottom here is the epidemic curve. So showing the number of new cases reported each day. So these are by date of report. These are the publicly available data. And I've also tried to put in a little bit on the timeline of what has happened, and I'm going to try to do a little bit of interpretation for you about what's happening with these with the epidemic curve. So the first case, it doesn't actually seem to show up here, but the first case was reported on the 5th of March, and at that time they had been doing they'd been testing for a while, and I think we're really sort of expecting to get a case. And so once there was a case, things moved pretty quickly. There was a state of disaster declared on the 15th of March. And then on the 18th of March, they instituted the first big round of interventions. And that included school closures, a travel ban, and restriction on mass gatherings. So this red arrow is indicating when that started, and then it's all of those things are still in place, and I expect that they will be in place for a while. The next thing that happened is we saw this sort of what looked like exponential growth. So there was a doubling time of sort of between 2 and 3 days over a period of a couple of weeks, and people got really worried. And the government at that stage implemented one of the strictest lockdowns that has been implemented anywhere, not anywhere. Wuhan certainly was stricter, but a very strict lockdown, essentially shutting down most of the economy. There are certain sectors of essential work are basically healthcare workers and grocery stores, and some things related to trade, but and security. But almost everyone is sort of told to stay home and not allowed to leave their houses. You can leave your house essentially to go grocery shopping, or if you're an essential worker. No outside exercise, nothing of that sort. And that lasted for 5 weeks, from the 27th of March to the end of April. And at that point, there was starting to be a lot of sort of consequences of the lockdown, and it really didn't appear that there was a lot of transmission going on. And they started talking about easing up the restrictions. And so on the 1st of May, we went to what's called level 4 lockdown, which is very similar to level 3 lockdown, except that a lot more people are allowed to go to work. So they've opened up additional aspects of the economy. So now restaurants are allowed to deliver food. You still can't go to a restaurant. You can't go and get takeaway, but you can have food delivered to your house. And animal services are open, and you're allowed to walk outside between the hours of 6 a.m. and 9 a.m. So it's still a pretty strict lockdown, but slightly less strict than it was. And so that sort of is happening in parallel with this epidemic curve here. So what I said before is that we saw this little period of what looked like exponential growth. The lockdown came in and it almost immediately went away, which I think is in some ways deceptive. Well, I think it's pretty deceptive. I think what was actually going on is most of these were travel related cases. The testing criteria were very strict in the beginning and didn't change until the beginning of April. So the testing criteria were basically that you were allowed to be tested if you were a contact of a case or had a known travel history to a region with transmission. And so the travel ban, which started a couple weeks earlier, is probably why the cases suddenly seemed to go down right when the lockdown started. And the testing criteria didn't change for a couple of weeks after that. So I think really there was a period in here where there were no more imported cases and very few contacts of imported cases where we just weren't testing anyone else. And then slowly, even though the criteria changed at the beginning of April, it took a while for testing to ramp up. But slowly it did start ramping up, and eventually we did start seeing cases that are really attributable to community transmission. So I'm already way behind where I wanted to be, so I'll keep going. So this is the not the age distribution of cases, but the total number of detected cases per 100,000 population. And I think this is interesting because it shows sort of, you can think of it as sort of an indicator of risk. So it's showing the blue, or the males, showing that older males are definitely experiencing higher risk of clinical, or at least of diagnosed disease. But also that women in the sort of childbearing years up to sort of the early 50s, and this is I find this concerning because this is the age group that has the highest HIV prevalence, or sorry, the demographic groups that have the highest HIV prevalence. And so that's the first indicator I've seen that there may be something going on with HIV, and that could be quite scary. Okay, so moving on. So I mentioned that testing has been changing through time. There's sort of 3 different types of testing that are going on. We have community screening and testing, which is where people are going door to door, doing a symptom screen, and then anyone who has 2 or more symptoms is being asked to go get tested. There is contact tracing still going on of known cases. And then we also have passive surveillance where they're testing people admitted to hospital, especially people with pneumonia, but also I think more broadly now people with any sort of respiratory symptoms. And they're also now regularly testing healthcare workers, which I didn't have on here. Interestingly, the testing has been going up dramatically, but the positivity has remained around 3% since mid-April. So that indicates that, I think that indicates that there is, what we're seeing that's looks like exponential growth is not just due to testing. I think if we were expanding testing at a rate that was that was faster than the epidemic was growing, then I think we would see a decrease in positivity. That said, we've also had a lot of struggles with testing. So this is just a headline from yesterday, the day before, saying that there's backlogs in patients waiting for tests. And that's definitely the case there. The national labs are having a lot of trouble getting the reagents that they need. As someone mentioned, it's also the case in other parts of Africa. And there are definitely big delays in the testing. And I think that is definitely meaning that the numbers that we're seeing, even though we're now seeing 600 or 700 cases a day, I think those are being artificially deflated by the testing capability. Okay, so moving on a little bit to what's going on right now. So the majority of the cases at the moment are occurring in the Western Cape. So that's this area in pink. And the pattern that's being seen, this is going back to what I said at the beginning about the levels of inequality. And so what happened early on is that there were travel associated cases. Those cases were obviously in the more affluent populations. It now seems that the infections have more or less disappeared from the affluent populations where social distancing is relatively easy to implement, and people were sort of relatively well educated and responsive to sort of the international panic. And what has happened instead is now the infection has gotten into really densely populated, really poor areas. And I have, sorry, I'm very conscious of that I'm over time. So I'm going to try to speak quickly, but the areas here where the most cases in the Western Cape are occurring, Tygerberg and Khayelitsha, are both what are known as townships. Khayelitsha is the largest and fastest growing township in South Africa, and it is partially a formal settlement and partially what's known as an informal settlement, which is sort of like a shanty town in most places. And this is an area where nearly 500,000 people live in 39 square kilometers. You can see here, so these are both just pictures of Khayelitsha from different angles. So you can see these are very sort of poorly constructed houses that are right up against each other. Many of them have, you know, single rooms with 5 to 8 people living in them. And you can see here along the fence line, these are actually essentially porta potties. So these dwellings, for the most part, do not have running water and do not have sanitation facilities. And so if you think about what social distancing means in a context like this, I think it's, I'm not sure what it means, but I think it's something that is virtually impossible. And so I think that's what's happening is we've had this really strict lockdown, but despite this really strict lockdown, we're still starting to see exponential growth. And I think it's in these areas where the lockdown has very little effect because people can't get away from each other. It's impossible to distance. And in these same areas, there are other effects of the lockdown that really need to be taken into consideration as we start thinking about exit strategies. I think it's balancing these different effects that's going to be the real key. And so just very quickly, there was a survey done by the Human Sciences Research Council in South Africa that was looking at sort of some of these other aspects of the lockdown. They found, they were looking at things like access to food. So they found that just under a quarter of residents, that's not residents of informal settlements or of townships, that's residents of the entire country. A quarter had no money to buy food, and that went up to more than half in the informal settlements. And 2/3 in the townships. Oops, sorry. And so I won't go into details, but they also looked at things like access to chronic medication and ability to pay bills and to earn an income. And these are all just shocking numbers that sort of illustrate the lockdown consequences that are unrelated to the coronavirus. And so I think that is sort of where we are in South Africa, is that people are desperate for other reasons for the lockdown to go away. And these are very valid reasons that also have an impact on health and on well-being and even on mortality. But at the same time, we're in a situation with an exponentially growing epidemic, even with the strictest lockdown that we could have imposed. And so I think we're at a stage where we have to make, as a country, we're going to have to make a decision about whether whether the lockdown really can do anything, and whether we should say, sort of throw up our hands and say, okay, we're going to have to deal with the coronavirus in its full force in order to get people, you know, money to eat. So I think those are some of the issues related to sort of Africa-specific settings. I think there are others that I haven't touched on, but I know I've talked for way too long, so I'm going to stop there.
Fantastic. Thank you very much, Juliet. I mean, I think you raised really important points about equity and the sort of indirect effects of lockdown on other aspects of life. We're a little bit over time already, but if there are any questions for Juliet, please put your hand up on Zoom. I mean, how closely are you working with the sort of Ministry of Health? Is there a sort of a SAGE equivalent in South Africa?
Yeah, so I can, yes. So I have a few slides that I decided not to show for the sake of time about that. So we have something called the South African COVID-19 Modeling Consortium. And then it's sort of, it's somewhat overlaps with the Ministerial Advisory Committee of the Department of Health. And it's a very, in some ways, very different beast from SAGE and from SPI-M in ways that I would be happy to talk to people about offline. But yeah, so we are doing modeling specifically for the government, and we're hoping to be able to release our models, our reports. We have 3 reports that we've written in the next couple of days, but we're sort of under negotiation.
Great to share them when they're able to be released. Tom, you raised your hand, you have a question.
Yes, so I wrote a question on the chat, but I can read it out here. So it's not particular to South Africa, but my question is, why are there so many fewer cases and case fatalities in Africa as compared to Europe? Is it climate differences, that it arrived later to Africa, or that it's higher underreporting numbers, or that the restrictions are more effective, or what is your, why is there so much fewer cases in Africa compared to other continents?
I actually think, Tom, that's a fantastic question to take into the next session, because I don't suppose anyone's got a quick answer to that, but I know we're discussing the broader issues after a tea break. Julia, if you want to give a quick response to that. And
yeah, sure. So I think it's a combination of the fact that there were restrictions that were implemented really early on, and the sort of all the things you mentioned, but I think the early restrictions are part of it. And I think what's really happening is that there's a delay, and that we really are going to see those increases in case numbers and deaths as soon as people start lifting the restrictions.
Thanks very much.
I think we're already starting to see it in South Africa.
Well, fantastic. Thank you very much to Juliet, Carl and Matt for giving those excellent talks. I'm going to hand back over to